Welcome to a risk-benefit discussion about bariatric surgery. You're probably someone who's interested in bariatric surgery, at least interested enough to learn about it, and you probably have appropriate concerns about whether bariatric surgery really will be a health benefit for you versus a health cost or a health risk. Or maybe you're fully on board with the idea of surgery, but you've got a skeptic in your life who's pulling the risk card to hold back on the idea of bariatric surgery. Well, I'm John Pilcher. I'm a bariatric surgeon in San Antonio, and these are the types of discussions that I have with patients all the time. I think they are completely appropriate discussions. I'm going to give you some information that I hope will help you balance the risk versus benefit of bariatric surgery in your own life. And we're going to talk about some specific risks, or kind of outline the big and the little risks after bariatric surgery. And then at the end, we'll circle back and I'll give you some ideas about how to take control of your risk as you get closer to surgery. I'm going to begin by wrestling with the biggest risk around surgery, which is the chance of death caused by the surgery. Sleeve and gastric bypass, these are real operations. We are working internally on vital organs, and we're doing this under full general anesthesia. So what we're doing is we're adding the controlled stress of the surgery to whatever pre-existing stress that the obesity disease has caused, the stress that the patient brings into the surgery. And then there's the small but real chance of complications from the surgery, and that stress, the stress of complications, together with those other pre-existing stresses, leads to a very small but a real chance of dying from the operation. And I think it's also true of most bariatric surgeons who are busy across the country. I have lost a few patients over time from operations that I've done. For me, those few cases were all many years ago. And each of those few cases were situations where we knew, that would be me and the patient and the family, all knew that these were high-risk situations going in, because these patients came to me at a later stage in the disease with lots of strain before the surgery even happened. But on the other hand, as I think about my very large group of patients, both high risk and low risk, I feel confident saying that I've helped people gain many years of health and life through bariatric surgery. My direct patient experience has been very positive, but you don't just have to take my word for it. Many research studies have been done worldwide to test this idea that bariatric surgery saves lives in spite of short-term risk around surgery. To demonstrate this, I've selected one research study done by one of the outstanding researchers in the field. His name is Dr. David Arterburn. This diagram is called a Kaplan-Meier curve, and it plots out the cumulative mortality of a bariatric surgical group on the yellow line compared against the cumulative mortality of a group of matched people with the obesity disease who did not have surgery on the dark line. You can see that the surgical group has more deaths in the first couple of weeks after time zero, which is the day of surgery, but then the surgery plot runs flatter than the non-surgical group for a long time. At about 2 years and then into the distant future, the risk of death is less than the risk of treating the obesity disease without surgery. For perspective, I want you to know that I intentionally chose a study where it was kind of an uphill battle for bariatric surgery to prove its thesis of saving lives. This study by Dr. Arterburn looked at VA hospital patients who were operated on between the year 2000 and 2011. And the reason that's a good stress test for bariatric surgery on this claim is several-fold. First of all, VA hospital patients are typically male. They're typically older and sicker, meaning they have more comorbid medical conditions in comparison to the general U.S. bariatric population. All those things made the risk of bariatric surgical patients at the VA at that time higher than for the general United States bariatric surgical population. In addition, the time frame of the year 2000 through 2011 was the time frame when bariatric surgery was transitioning from open bariatric surgery, which had higher risk, into laparoscopic bariatric surgery, which has lower risk. But the transition, especially at the VA hospital system, led to higher risk during that time. So the fact that this study showed in a pretty powerful and statistically significant way that even in these sort of challenging conditions, it saved lives in comparison to standard obesity treatment is a pretty strong endorsement. So not only have numerous other studies confirmed this finding that bariatric surgery is a lower risk than living with the obesity disease, other studies have shown some very interesting findings showing dramatically reduced risk from death of cancer with bariatric surgery and dramatically reduced risk of diabetes death after bariatric surgery. And so we're not just talking about a risk benefit of bariatric surgery versus zero risk in normal life. We're talking about a risk discussion of bariatric surgery and its small short-term risk around surgery versus the risk of living with the obesity disease over many years. Having said that, we're going to expand the discussion into other risks that may take place around bariatric surgery. Before we leave the very serious topic of mortality risk around bariatric surgery, I'm going to give you one other way of thinking about this or putting it into perspective by comparing the mortality risk of bariatric operations alongside the mortality risk of some other common surgical procedures that are widely accepted. So this histogram gives you information about bariatric surgical risk with a mortality rate of 0.3%, that's 3 out of 1,000, compared to appendix removal at 0.1% or 1 out of 1,000, gallbladder removal, which is also called cholecystectomy, at 0.15%, coronary artery bypass grafting, which is pretty big at a 5% mortality risk, and total hip replacement, which is in the same ballpark as bariatric surgery at 0.3%. Again, that's about 3 out of 1,000. I chose to open this discussion about the risk-benefit of bariatric surgery with the big risk, which is mortality, for two reasons. One is that mortality is kind of the elephant in the room if we don't talk about it. So I felt it was best to bring this out, to understand where it fits into all the rest of the facts, and then to use it as a perspective going forward. In fact, the second reason is that the mortality risk benefit is not a bad benchmark for the balance of all the other risks, the risks of surgery versus the risks of the obesity disease. And as we'll discuss, there are risks with surgery. We're going to outline those. And I want you to keep in mind, again, this is a balance of risks of the disease as well. So think about your complications from diabetes, think about joint failure, think about stroke, think about chronic pain from obesity, think about, I can't get on a roller coaster with my kids. And so just like the mortality risk is there with surgery, but it's less than the risk with the obesity disease, as I think you're going to see, the risk of all the other problems with surgery is there, but it generally works out to be less than the risk of all the obesity-related conditions. Honestly, it's beyond the scope of this video to give you an exhaustive, completely detailed list of all the potential bariatric surgical complications. But yet I think it's fair to give you an outline of some of the most important ones and some of the slightly more common ones so that you have a good feel for the surgical side of the risk equation. Thinking about the obesity disease side of the equation, I need you to think about the risks that you may be facing in your own personal life. And yes, obviously the obesity disease risk list is way beyond the scope of this video. Okay, so moving into surgical risks, I'm going to start with what I call the big three risks. These big three are all very rare, but I mention them first because if they happen, they're very serious. Okay, so number one of the big three risks is the chance of leak. All of our bariatric operations, from the sleeve to the gastric bypass to the duodenal switch, involve alterations of the gastrointestinal tract, the stomach and the intestine. And for the purpose of this discussion, it's a kind of okay to think of this as a plumbing project, okay? We're moving stuff around, we're leaving behind some seams or some new connections, and it's very important that those seams or those connections or those plumbing spots need to leak not even one single drop. And they need to leak not at all, because every little drop of digestive juice or food or saliva, the stuff that's inside the stomach and the intestinal tract, is very caustic or inflammatory. And so even if one drop leaks out, that will cause more inflammation and cause progressive leakage, and it's a big problem. Now, having a leak after one of these bariatric operations is usually not lethal or life-threatening, but it can be, and what it almost always leads to is a dramatically extended hospital stay and multiple additional procedures to repair or patch the leak or to get it to heal. It may also involve IV nutrition and artificial nutritional support in the long run. So leak is quite rare, but it's a very big deal. Risk number two is a small chance of bleeding. Now, the diagrams that we typically use to demonstrate our bariatric operations don't show all the blood vessels that are involved when we cut the stomach and we move the intestine and we seal these things back together. And it's understandable. The artist is trying not to clutter up the diagrams so that you as an interested layperson can still understand what we're doing and how we're changing the shapes. But the fact is that when we do these operations, we cut and seal multiple small blood vessels inside the abdomen. And trust me, we have excellent tools to do this, and also trust me that at the end of the operation, we surgeons routinely look around to make sure that there's not any bleeding before we pack up and close up your skin incisions. Okay, but in the recovery process, in the recovery room, your blood pressure may run high, or you may receive some blood thinner for good reasons I'll talk about in a minute. And either an elevated blood pressure or blood thinner may cause some of those sealed blood vessels to pop open, and so you may have bleeding after the surgery. Bleeding is obviously serious, and bleeding sometimes requires reoperation to fix it. The good news is that if bleeding happens, it almost always happens within the first 24 hours when patients are under close observation, so that we can get on top of it and we can fix it. Incidentally, my partners and I changed protocols a couple of years ago so that, knock on wood, in the last 2 or 3 years, we have had 0 cases of bleeding and 0 cases of needing to reoperate for bleeding. The third of these rare big 3 complications is the chance of what's called a pulmonary embolus. Now, pulmonary embolus begins as a blood clot in the legs, and this blood clot in the legs can break off and go up to the lungs. Of course, this pulmonary embolus thing can happen with any of the bariatric operations, but it's something that fits with surgery overall. So this may be a risk with your cesarean section, your appendectomy, your knee replacement, your gallbladder surgery, etc. And the best way to control the risk is twofold. Number one, we want our patients up and walking as soon as they can stand it after surgery, maybe before you want to. We like to say walk early, walk often. And the second thing is that we surgeons are often going to administer blood thinner that further reduces the chance of clots. In our own practice, this has been a very rare complication. We have a great team that's good at getting patients up and walking. And so we haven't had anybody die from this since one of my patients back in 2001. That's one of those few patients that I mentioned earlier that we'd lost after surgery. Moving beyond the big 3 risks, it's a little more common for patients to have lesser problems or side effects from the surgery, such as nausea, abdominal pain, dehydration. Most often these problems, if they happen, will come up within the first couple of weeks. We'll treat the patient through them, and then patients will do well in the long run. About 2 or 4% of our patients may need transient episodes of IV fluid administration to get them through some difficult times when they're not hydrating very well, and that's usually not a long-term thing. About 0.4% of our patients, that's 4 out of 1,000, may have months of abdominal pain or nausea or need for IVs. I hope 4 out of 1,000 sounds pretty uncommon. We think it's pretty uncommon, and trust me, we will stick with you until you're doing well. Thinking further down the road, there are several medium and long-term problems that I'd like to discuss as well. First of all, there's the chance of vitamin deficiency. The sleeve and the gastric bypass both reduce the absorption of iron and B12 to some degree, and maybe other vitamins. All of bariatric surgeons are going to recommend that you take some bariatric vitamins regularly for life after the surgery. Our experience has been that when patients take the vitamins regularly, and when they have their follow-up appointments and do the routine lab checks, if deficiencies show up, which happens, it's not super common, then we're going to be able to fix those deficiencies and find them at a stage where they're just lab abnormalities and the patients don't feel bad. These are all correctable. Parenthetically, I will add that duodenal switch has its own set of vitamin deficiencies. Part of its function is reduced absorption, and so there's a bit more of a chance of vitamin deficiency there. The second thing I'd like to talk about here is hair loss. And for both our sleeve and our gastric bypass patients, about half of our patients will have significant hair shedding. It seems pretty impressive, usually at 4 or 6 months after their bariatric operation. And it seems like this would be, you would intuitively think this is a nutritional problem, but it's not. It's actually a situation of hair growth being on pause as a stress response from the surgery. And then when the hair growth resumes, this is 4 to 6 months after surgery, a lot of the disconnected hair sheds or comes out almost all at the same time. The good news is that the hair comes back. Third thing, loose skin. And here's the situation with loose skin. The big news is that skin rarely is able to shrink all the way back to where it was at the beginning. And so what I think makes sense is to get your obesity disease treated before you get too big and before it gets all stretched out. The other good news thing is that most patients I meet, really 98% of patients, are not people from My 600 Pound Life, the TV show. That's where the skin loosening and floppiness is really dramatic. The vast majority of people are going to get some decent skin shrinkage. They're going to look okay in clothes. They may choose to have some plastic surgery down the road, but for most of them this shows up as a choice and not an emergency need. The next topic is reflux, which is mostly a sleeve situation. What we're seeing in long-term research is that for sleeve patients, once you get beyond about 5 years from the surgery, approximately 1/3 or maybe gradually more of the patients will have some heartburn and reflux, enough that it needs treatment with medicines. This almost always can be treated with meds. Every once in a while, the reflux is bad enough that meds can't keep it under control, and we need to change over to gastric bypass, which is a different big deal, but at least there is a treatment plan. Next, I want to talk about bowel obstruction. That's blockage of the intestines, and this is something that almost never happens with the sleeve. It's more of a concern with gastric bypass and with duodenal switch. Having said it happens with those operations, I still can tell you that it's quite rare. It runs about 0.5% lifetime for gastric bypass patients, and that's about 5 out of 1,000. The bad news on bowel obstruction is that if it occurs, it typically needs urgent surgery to fix it. Usually people recover well if they get to the surgery, expeditiously. The way people know if they have a bowel obstruction is they have pain and bloating and nausea. The last topic of concern that I'm going to include in this video is the chance of weight regain. And the odds of weight regain, first of all, are much less than they would be with non-surgical treatment, talking about lifestyle and medicines, but yet it's real, and so it's worth talking about. And the statistics are that about 1 out of 3 sleeve patients may gain substantial weight back over the years. About 1 out of 5 gastric bypass patients may gain substantial weight back, and about 1 out of 10 duodenal switch patients may gain weight back. Here's the key differentiator. We see that weight regain percentage is much less for any of the operations if patients are maintaining their planned follow-up. Our plan, and I think the plan for bariatric programs across the country, is that we need to stay engaged with our patients for life, because we recognize that we're not curing this obesity disease, we're just getting it under better control, and that control may require some fine-tuning. We are happy to help, we want to be here for you, but you got to come into the office. At this point in the discussion, most patients have 2 very reasonable questions. Number 1, what's my personal risk? Like, what am I looking at for surgery? And number 2, okay, I know I'm going to have some risk. How can I reduce that risk to the least possible? Those are good questions. And so for the first one, you need to meet with an experienced bariatric surgeon. And most surgeons are going to be able to learn your medical condition and to know the surgical options and to give you a very reasonable risk assessment, give you a good idea of what you're looking at. Surgeons actually have online surgical calculators that can be used in case you want to get some numbers, a surgical risk calculator. The second thing about optimizing or reducing your own risk, I think there are 2 categories of action to take there as well. The first category actually is to decide on surgery earlier in the obesity disease process rather than later. Okay, and this may sound strange, but there was an old-fashioned idea about people ought to be near unto death with their weight before they chose bariatric surgery, keeping bariatric surgery as a last resort. And that may have been reasonable at the inception of bariatric surgery back in the early 90s, but these days in the setting of modern bariatric surgery, it's really the opposite of what you want to do. And if you think through this, you can understand that people who have gotten to be older and sicker are going to have higher risk of surgery and less chance of getting health benefits. On the other hand, people who are younger and not super sick are going to have the lowest risk and the best metabolism and the best sustained weight outcomes. Now, I'm not trying to create an unusual red lights flashing, emergency rush into surgery thought process. I and bariatric surgeons fully support people working on lifestyle intervention for their obesity disease first, and medicines, which are getting better all the time. It's quite an exciting change in our field to use these tools, these non-surgical tools, these non-permanent tools, to try to get the obesity disease under control first. And even if we go to surgery, we're going to use those tools as building blocks. So these things are going to work synergistically. It's not one versus the other. But unfortunately, the experience is that once a person has gotten into the medium or certainly the later stages of the obesity disease, once you're 50, 70, 100 pounds overweight, once you're on medicines, it's hard for those non-surgical options to be fully effective. And so what I'm advocating is that, yes, you employ the lifestyle change, and then if necessary, if it's appropriate, employ the medicines. And if those things aren't effective, don't wait 10 or 15 years before you think about surgery. Think about surgery once you've given the other things a good try, if they're not working in a lasting way. Okay, so that's number one, is to think about surgery early rather than thinking about surgery at the end of the whole obesity process. The second thing is to follow your surgeon's instructions. Your surgical program is going to have some particular instructions about what they want for your food plan, potentially for testing that they want to understand your medical condition better, perhaps to optimize your condition, and this would be things like testing for sleep apnea, doing cardiology testing, stopping smoking, and then your surgeon's very likely going to have a plan for reducing the enlarged size of your liver in the time period leading up to surgery. So different surgical programs have different preparation plans. Those are plans that they have had positive experience with, and I want you to follow the plan of your surgeon. So winding up, and in full transparency, there are a variety of big and little risks that you have to think about as you're considering bariatric surgery. I hope my positive personal experience and a little bit of information from the literature has given you the information that you need to put these things into perspective in your own life and to make a balanced decision about those surgery risks versus the risks that the obesity disease is imposing on you. Oh, and by the way, bariatric surgical patients save a lot of money over the years on healthcare costs. That's the topic of a video that I published about a month ago. And in the end, I want to recognize that you may be on board with the idea of surgery, but you may be facing opposition from some skeptics in your home. I hope this is useful information for them as well. In the end, you've got to make your own decision. I wish you the best of luck on your journey.